enough, we're almost ready to kick off. And it gives me great pleasure to introduce Dr. Frank Casey. And Dr. Casey is consultant paediatric and fetal cardiologist at the Royal Belfast Hospital for Sick Children. He's also an honorary senior lecturer at the Department of Child Health at Queen's University. Am I right?
That's right,
Yeah. He graduated from the National University of Ireland and trained in paediatric cardiology in Belfast and at the Hospital for Sick Children in Toronto. So it gives me great pleasure, and as usual I'm going to leave it up to the expert to tell you what he's going to talk about. So thank you, and thank you for making the journey today. I know that you had to be somewhere else, and we really do appreciate you being here. Thank you very much.
Thank you very much, Margaret, and thanks very much for the invitation to come and speak. It's a pleasure to be here, and I never thought I'd be giving a talk looking out on the pitch at Croke Park, but so it's nice to have that opportunity too. I suppose was left a bit of a broad remit as to what I would talk about today, and I just wanted to talk a little bit about how we achieve the best long-term outcome for children with congenital heart disease. And I'm not going to talk about it, I suppose, so much in terms of hard medical facts, but in the light of some work that we've done in Belfast over a number of years, trying to look at how we can get the best overall outcome in terms not just of a medical outcome with surgery and treatment, but an outcome that integrates the child into the family and into school and subsequently into adult life. So if I can just share a few of the things that we've talked about. I suppose the last generation has really seen a transformation in the outcome for children with congenital heart disease, such that 85 to 90% of children now born with congenital heart disease can be expected to survive through to adulthood. And one of the quotes that I read many years ago, which by a guy called Bob Anderson, who was a cardiac pathologist, and he said that the last 30 years of cardiac surgery had been like this exhilarating, breathless tour of the Himalayas, solving all the great problems. And what he highlighted was that we now must address the irritating question of what has actually been achieved and what kind of life we're offering to all of the children who have cardiac surgery. So he put it a bit more eloquently than I could have. And so when you start to think about what we need to get right when we're treating children with heart problems, the first, I suppose, priority is to give that child the best quality of life possible, and also to give the family the best quality of life possible. And for the child, that means appropriate participation in a lot of normal childhood activities, and then to try and equip them, not just in a pure educational sense, but in the more holistic sense, to give them the necessary life skills to achieve independence as they reach adulthood. And I suppose in my experience there are a number of key stages where you need to get things right. I often think that the very first encounter with a family is the most important one, because that sets the tone for everything that happens beyond that. It's usually at a time when parents are obviously very vulnerable and very traumatized by just getting a new diagnosis. And I suppose more and more that event actually occurs antenatally now. In about 55% of our patients with major heart disease now, the diagnosis is made antenatally through scans done initially by ultrasonographers and then by our own fetal cardiology service. The next key stage in terms of advice and getting things right, I think, is a discharge from hospital, because that's a big step from you when you move out of the hospital. We have all the supports out into the home, and we've some programs that we've put in place to try and support people at that stage. And then the next big step is going to school. Even for a healthy child, it's such a trauma for parents whenever their child goes to school. I can remember my own children going to school and how difficult that is to sort of let them go into the school environment. And then if those of you who have teenagers will be aware of the transition to the adult cardiology service. And so it's going back nearly 10 years ago now, we decided that we would put together a project to look at how we might try and improve the outcomes for children and their families. And it was a project which we called the Congenital Heart Disease Intervention Programme, or CHIP for short. Maybe not the most healthy name for a heart project, but that's what it was called. And what we wanted to do was, there are lots and lots of studies in the literature and research about the effects of heart disease on children and their families, but we wanted to try and do something that might actually change that. We thought we had enough information about what the problems were, but we thought we would try and do something about it. So we put together this project because we thought we would try and, if we could, get the parental attitude right to their child at the start, because we know from the literature that poor adjustment and anxiety relates more to the attitude and how the family respond to the problem rather than the actual defect itself. And our own work, Chris McCusker is a clinical psychologist who works with us, and whenever we came through this whole process, that's again what we found, that the family processes are the most important thing in influencing behaviour. So the project was a multidisciplinary one. We had input from clinical psychology, from our own paediatric cardiology team, from nursing, from general paediatrics, and from the technical side. And it was funded mainly by a grant from the National Lottery in the UK. We got a grant at the time of £300,000 to do the project over 2 to 3 years. And the aims of it really were to try and improve the outcomes by trying to promote better coping skills with the parents, to promote infant development. We had a nurse who looked at all the feeding behaviours, bonding and attachment, and who spent a lot of time with the families in the first 6 weeks of life, to try and reduce the sort of sick behaviour in children, so that they wouldn't see themselves as being a sick child later on, and to try and provide an overall care package. So, without going into all of the details because the time is limited, how was it done? Well, it was done by strategies of problem prevention therapy, giving parents a lot of appropriate information. And I should stress here that it was information that was appropriate for their particular child in their own situation, not just general information, but basic skills on how to face the problems, and the psychologists were very involved in that. We produced this thing, a self-help manual, and I brought one or two with me today just to show you, but this is just a manual that was produced out of the project. It basically deals with all of the things that parents and families face in the first few weeks of life, and I heard the previous speaker speak very eloquently about all of the how to deal with problems, and one of the things is to have something that you can read while you're on the ward. We produced a video, now a DVD, moving on with the technology, called Surviving Congenital Heart Disease, where parents actually told their story, and it was filmed on the DVD. And that was one of the most powerful tools of all, because no matter what we as professionals say, sometimes listening to a parent who can tell how they went through exactly the same situation as you're going through is most important. We printed fact sheets to go to the patient's GP and also to their teacher in school. We had two groups. We had an infant group and then a school age group. And so we give these fact sheets to children, to the GPs, to those that were involved with them. And the teachers' ones were particularly appreciated because, as I'm sure some of you may know, that sometimes when the child goes to school, there's this fear with the teachers as to what's appropriate for them to do. So we were very specific about what could be done. And then we tried to do formal exercise testing on the children to demonstrate to the families what exercise their child could do, what they could do safely, and what were the correct parameters for them. And one of the very practical problems that we ran into for 4 and 5-year-olds is that there is no good exercise test. So we had to go back to the drawing board and actually design our own bicycle. We worked with an engineer to try and design a bicycle that was suitable for parents. I've mentioned already the sheets, and I'll come back to some of the results, but what we did was, at the start of the program, we introduced all the measures that I've said to you, and then we analysed all of the impact a year later. And we measured some things like maternal mental health. These were just on questionnaire scores and by interview with psychologists. And the blue line there represents a reduction in things like anxiety, maternal mental health issues in those that were involved in the project, as opposed to the pink line there, which is the control group. It was a control group compared to them. The control group just got the standard care, and the intervention group got the package that was involved in the CHIP project. this is the fathers. Well, fathers, I suppose, like all men, we try not to engage as much as with things that are in relation to the emotions and open up a bit more about that. So the fathers perhaps got less benefit from our program, mainly because the focus was in fact on the mothers, and they were most constant beside their child in the hospital. An important finding was that the strain on the extended family for those who participated in the project was reduced, and that was a very important thing for us because, as you all know, it has an impact on siblings and on the extended family as well. So the intervention did help. One of the other important findings was in terms of sick behaviours, visits to GPs and other sick behaviours displayed by the child, that was reduced by where the family was in the project. So all of the measures seem to help bring the stress on the family down to a reduced level. I mentioned earlier about the exercise testing, and that was one thing that we had to try and explore a bit further. What we wanted to try and do in terms of exercising the children was to make them do something that was enjoyable and it was physically suitable for them and that was reproducible, that we could check their exercise level later on. And so this is what we had to design. It was just like a stationary bike, just a fun bike really to try and let the child exercise on it. You'll see this a little bit more in a minute, but basically the child was able to pedal on it. There was different levels of resistance where we could do formal testing. This is him, this little boy, all wired up. We did constant ECG monitoring and blood pressure monitoring while they were on the bike. And we wanted to demonstrate to parents that it was safe for the children post-cardiac surgery to exercise. And one of the most powerful things that came out of that was that parents sometimes were amazed by how much their child could actually do. I hope this video should play. This is this little boy now starting his exercise, and that's myself just telling him what to do along with one of our technicians who managed the machine. He got a little practice first of all to get used to it. And what I'm pointing to there are these lights that you see flashing. I hope you can see them okay. But the main incentive was to get as many lights as you can to flash, because that was the incentive. For young children, they just get bored if you tell them. You can see he's really going at it there now. And so he was quite competitive in terms of trying to light up as many as you can. And we were able to get real information on the ECG, as you can see here, looking at his exercise time, how his heart rate and blood pressure responded to exercise. So it was useful for him, useful for us, and I think most useful for the parents who observed this. We did this on quite a number of children who came through the CHIP project. We had 2 different protocols and just got very useful information. And these are some of the comments that parents had for us in terms of how useful that bicycle test was. So it's something that we've used since the CHIP project in terms of trying to get good measurements and to use it in that setting of reassuring parents. Unfortunately, the technology has moved on now, so we have to update it into a much more sophisticated piece of machinery. So I just wanted to focus a little bit on exercise, because not just in the young children, but in the adolescent group, I'm going to talk a little bit about it. It's an issue that parents ask me a lot about as to what's important with exercise, and not just with children who have congenital heart defects, but because of the issue of sudden cardiac death, there's also concern out there of parents of young people who are participating in sport. And exercise doesn't just have a physical benefit, it has a psychosocial benefit in terms of mood and self-esteem, and so it's very important therefore to include it where it's appropriate. And before I move on just to the adolescent group, I just wanted to let you know that I've shown you some of the early effects of the CHIP project in terms of alleviating the family stress and anxiety. We've just started now to follow the same group of children 7 years later after the initial project, because it's all very well maintaining an improvement early on, but we want to see if the benefits that we set in the early stages of life, whether they're maintained. So hopefully in the future we'll be able to feed back to you what happened in the long term to see if the benefits in terms of both family stress and the child's neurodevelopment and integration are maintained. I wanted to move on just for the second half of the talk to look at something that we've done a bit more recently. And this is, we tried to, I suppose, engage almost the same concept as the CHIP project in a teenage group. And I have to say that with the teenage group, it was obviously practically much more difficult. The first difficulty is getting that age group to actually engage with you, because you have a lot of 13 and 14-year-olds who basically don't want to see you, and they grunt at you when they do see you. So they don't really want to focus on their problem, and so we had it was a bit harder work to get them engaged with us. But I think in the end we managed to make it enjoyable for them and to engage in the project. So I'm just going to go through a little bit about that. As all of you know, the young population is the ever increasing one, and all of us who are now involved in care of young people with heart problems, the big population that's expanding is the teenage young adult population, a whole new population that we didn't have to deal with until relatively recent years. But it's also a time when these young people start to realize that they have had a problem, and many of them don't want to engage in talking about it, but it still preys on their mind, as I'm sure you're aware. And so one of the things that's often surprising is how little knowledge that the young people have about their condition. Because as cardiologists, I think sometimes that's our fault. Over the years, we've talked to the parents and imparted all the information to them. But it's getting the time right when you start to impart that knowledge to the children and to the young people as they come into teenage years. And all of the other things that I've listed there all become important issues for the young people as they get older. Things about careers. We know that adults with congenital heart disease are unfortunately at present twice as likely to be unemployed as their peers. And those unemployment rates are not related to the relative severity of their congenital heart disease. I look after some young people with very severe heart conditions who hold down a job, and others with less severe disease because of their attitude to it, mainly haven't been able to work. So career guidance is important in terms of guiding them along the right way. The exercise is important in terms of promoting their long-term health. And exercise limitation correlates with the actual diagnosis in this group. And so our hypothesis was that if we could, again, have a program of physical and psychosocial input with these young people, that we might improve their ongoing health in the long term. And so about 3 years ago, we set out on this project to try and look at a group of young people who attend our service in Belfast. I won't go into all of the details of the project, but some of the key things that were in it were that we did an activity questionnaire to look at what they did day to day and just some general questions about exercise. And then we had 3 questionnaires in terms of just looking at their psychosocial well-being, what their general mood was, their self-esteem, and whether they felt that they had control of their own well-being. Again, a similar exercise testing, except it's a bit easier in teenagers and young adults because you can use a standard treadmill. One little device that we got, it's a little device that we got sourced from a company in America, but it's that little red box there is what's called an Actigraph. And what that does, we asked the young people to wear it for a week, and basically it tracks their activity for a whole week in terms of movement and activity to see how active they are. Do they lead a very sedentary lifestyle, or are they involved in activity? And it's not too intrusive. We were able to download the information from it then to see what the young people actually did. And this is the kind of graph that we got for it. It processes their average activity counts per minute over a week. So it was a way of correlating what the young people were telling us they did and what we found that they actually did over a week at a time. So again, to make the study sort of balanced, we randomized the patients into people who got our intervention and those who didn't. The intervention was an activity day and a motivational interview. Because they were teenagers, we thought it would be better to try and not bring them to the hospital, so we brought them to the Queen's University PE Centre in Belfast, groups of them for a day. We had 6 different groups, and during that day we talked to them about exercise, lifestyle, diet, and we also got a motivational speaker in, someone who was a sports coach, who imparted to them the importance of exercise. And you know, it was quite striking the way the young people were taken by the people who were involved in coaching, because that was much better than listening to, you know, to doctors or people that they'd been familiar with. So we focused on what exercise they were doing at the time, and then at the end of the day we wrote out a personal activity plan for them to ask them to implement it over the next 6 months. And one of the doctor who was a research fellow involved in the project kept in touch with them during that 6 months by text and phone to see how they were getting on. The control group received the usual level of care, and then the participants that we had the activity program for came back in 6 months. I should say we also enrolled a dietitian who taught them about diet as well. And so there's a lot of numbers on this slide, but we, as you can see, we started out with a big number of patients that we identified as possibilities from our database. We wrote to some of them we asked them at the clinic, and in the end up we had 143 patients, which we were quite pleased with, that came to be involved in the study. And 71 of those just continued with their normal treatment, and 72 had the interventions that we outlined. And we did that and then reassessed them at the end. As with all studies, you always lose a few along the way who don't come back for the assessment. But we still had 101 patients who were reassessed at the end of the study. They had a broad range of diagnoses. These are the things we categorized them into the severity of their heart problems, from those with very minor heart disease to those with, complex heart disease that wasn't repairable, patients with one functional ventricle in the heart. I'm sure some of you will recognize some of the diagnoses there. And so we looked at things like anxiety for these patients. We did find that those with the more complex disease did tend to be more anxious about the condition, which is understandable because it had a bigger daily impact on their life. So those that had where it had the greatest impact were those the cyanotic, or patients with cyanosis who had, say, like a Fontan operation where their heart could not be corrected completely. One encouraging thing, though, was, and I find this with many children with congenital heart disease, that despite their problem with their heart, their self-esteem was extremely well maintained, and that their group means in terms of self-esteem was very favourable when you compared it just with the normal population. And even in those with the most complex disease, their self-esteem was well preserved. And I think that was a tribute to their parents as well as to the children. The health locus of control, what that really refers to is that patients felt that they had some control over what happened to them, and thankfully they did. They felt that it was reassuring to know that they didn't think that things were being done to them unfairly. Another encouraging finding from this was that of all of the patients that we included in the study, 93.7% of them participated in some regular exercise each week. Now, for most that was PE in school, and for some it was within certain parameters. But over half of the young people within the group across the range of diagnosis were actually playing a sport at least once a week. And the activity score showed no difference right across the board in terms of what they said they were doing. When it comes to formal exercise testing, as you would expect, the main group where the exercise was limited were the patients with complex cyanotic heart disease. But even those children displayed a moderate amount of exercise. None of them would have been in the category that we thought, or that anybody would have termed severely disabled. The mean duration of exercise was 11.23 minutes. And when I talk to my adult cardiology colleagues, with adults who go on a treadmill, most adults when they go on a treadmill do 7, 8, 9 minutes. So the children actually were performing well on the treadmill. There were some differences in the way the heart responds to exercise with the teenage group, in that they achieved a lower heart rate and that their oxygen saturation diminished with exercise, but no change in terms of their blood pressure. What was interesting in terms of the activity counts, I showed you that little device, was this graph where most of the children actually wore it for the time that they were supposed to wear it. The mean duration was 5.72 days, so that was good that they actually went along with wearing it. The interesting thing was that those patients who had complex disease were not the patients who sat around and watched the TV or played on the PlayStation. They tended actually to be more active on a daily basis, not doing sports, but just moving around, walking around, being involved in things rather than sitting doing sedentary activities. So that was, again, it's encouraging, because sometimes there's a concept that those with the complex disease are not enjoying life to the full, and I think that this kind of data allays that fear. What did they tell us about the exercise program? They enjoyed it. I think I have to say the teenagers did enjoy it. It made them think a bit more about exercise. They learned what exercise was suitable for them. And they also learned some lessons, I think, about a healthy lifestyle. There are a few who didn't, I have to say, engage with it, and that's, I suppose, to be expected. But one of the sort of unexpected positives from the intervention days where we brought those children and young people together, and they ranged from about 13 up to about the age of 20, was the actual interaction between the young people themselves. That was one of the, you could see as the day went on, like most teenagers, they were a bit reticent about talking to each other, first of all, when they didn't know each other. But they actually integrated very well, and that was a spin-off that we hadn't really planned. They loved the motivational speaker because it was kind of fun, and this was somebody who was kind of a well-known coach, and that to have someone like that speak to them meant a lot to them. So just to conclude, these are the findings in terms of there was very good uptake of the project in terms of right across the board. When we assessed these young people at the end of 6 months, we brought them back at 6 months and we did a formal exercise test again. And we found that those where we had initiated the program, whenever they came back to do the exercise test at the end of 6 months, they were able to perform for longer and better. And there's a big interest in this now in doctors like myself who look after young people with heart disease, trying to focus on whether some of the limitation that some young people have is due to the fact that they don't actually exercise enough rather than the limitation of their disease. So there's a kind of a happy medium, and we feel that with the appropriate advice around exercise and an exercise program that some of the young people can improve what they do. The activity counts again through the program. People became generally more active over the 6-month period. And a bit like the first CHIP project, we have to see if that's maintained, because it's a lot of effort to try and get these young people to do this, but what we want to do is change their lifestyle in the long term. The spin-off from feeling better about yourself with exercise is that you feel generally better, and I mean all of us know that in terms of the benefits of exercise, but it's equally applicable to this young group. So when we looked at the psychological questionnaires, they had improved as well. Self-esteem again improved because they felt they were able to do more. And so all of these were positive outcomes. And so finally, just to conclude, we find that younger adolescents with major heart disease, they may experience more anxiety than those with minor disease. The majority of patients, even with complex diagnoses, can participate in regular exercise. And that the Actigraph demonstrates that they're more active day to day, some of the complex patients. And peak exercise data shows that when they get to really pushing hard, that they will be a little bit more limited. And so finally, an exercise program is something that I think should be included in the package of care for both young and old with heart disease, with the young children going into primary school to make sure that they are integrated into exercise, that as they go through adolescence, that they do what's appropriate, because I think that will have a positive effect on physical and mental health. And so therefore we plan to continue with this kind of intervention to hopefully improve the long-term outcome for all of these patients. Thank you for your attention. Yeah, that's okay.
Does anybody have, I'm sure you do have questions, so they're listening. That was fascinating, really, and the results of the research as well were very, very interesting. So if anybody has any questions, Frank said that he's there to take some questions, so fire away.
Yes.
Is there any hope of you doing a study down south at all, or including some of our patients?
More and more we are working with our colleagues here in Crumlin, and that's where I was this morning actually talking and meeting with them. We would be very happy in terms of research projects to collaborate with the team here, because within the island of Ireland, I think it would be better if we included the whole population, and we would be very willing to do some of this work or share it with the team here. There's no problem with that. It would be something we'd be very keen to do.
It's just that you've done great stuff, the leaflets for teachers, the booklets and stuff that you were early on and all, and for starting school and all, that's really it's great as well. But the whole idea of doing of working with the children to see their limits and things, I think it would be fantastic. Just to see what they can do, and it's something I remember I was sort of researched when I had my daughter 9 years ago. I think it was at the early stages of when we're getting sent up to Queen's for your sort of what you were doing, and I thought it was really fascinating. And now she's kind of nearly heading into 10. It's definitely more of a challenge. I mean, she flies up and down slides in a water park, but yet carrying her bag to school. She's just been able to know those limits of where to push them and what to get the best out of them for their future life. As they get older.
One of the biggest concerns that, as I say, is fed back to me is what can they do and what's safe for them to do. And there are some where we have to say, well, certain things are not safe, but for what sometimes happens is that young children are inappropriately restricted in terms of what they do, and then that impacts on them in school and being isolated from enjoying things with others. And if you can demonstrate what's safe for them to do and have strict parameters, one of the things that I feel is most important is that their teachers actually know what they can do, and teachers are understandably very cautious when they hear a child has a heart problem, but for the vast majority of children, especially in the early years, they should be treated no differently than the other children in the class. And the first 2-3 years at school are so important in getting that right, So, yeah.
I would find, say, with my fellow that after, say, a day of school, he could be wrecked tired.
Yeah.
Really, really tired. And I would get told off, like in the car or on the way home, or I get abuse going home. But there was one time we took him for a cycle, and we cycled from the top of I don't know where Dublin very well, but the Cabra Road right down around by where the Point Depot around there. There was a big cycle day on, and then we came up through town and back up through Constitution Hill. Now he couldn't manage Constitution Hill because it was a big climb, but yet he walked up it with me. And we got there, and my sister lives up at the top of Constitution Hill, so we popped into her for a break where we had to do that. But what he did, Dr. Kevin Walsh was even really impressed with say his ability that day, and so were we. We were really taken aback. So then you're kind of wondering, okay, what where are the limits like that? And what is he able to do, and going to bed a lot earlier to perform better the next day and things like that. Do you know what I mean? So I get very confused as to what his limits would be.
Well, one of the benefits of actually testing it formally is that you know that if we can know how far a child can go on the treadmill. But I don't know what your son's diagnosis is, but.
He has transposition of the great arteries, pulmonary stenosis, and a single left ventricle.
Yeah, well, with a boy with his diagnosis, you would expect that he would be more tired, after vigorous exercise, and you have to allow him, I suppose, that particular leeway. Sorry?
He looks after himself.
It's not. What you find is that young people with his kind of diagnosis will be more tired after a particularly vigorous day, and but they still, if they have something they especially want to do, they can push themselves that little bit harder. So for him, it would be useful at some stage for him, I think, to have just a treadmill test. He's about to.
Because there's one mother once said to me, it's like what they do is they put on a pair of high heels, like what we would do, we put on a pair of high heels, we run around the town that night and dance or whatever, our socks off, and we suffer for the next 3 days. And that's what I find, he would suffer for the next 3 days.
Well, is it do you kid, because you haven't got a heart thing yourself and you're trying to understand their feeling, how they feel inside them, having rest periods in between activities, because our daughter now has joined athletics. She's asked to do athletics, which is a nightmare for us, an absolute nightmare. But trying to build in resting periods in between activity, you're trying to explain it to the coaches, and this child is perfectly okay. About intermittent breaks or whatever, or resting periods. But it's trying to see. I think it's trying to understand what it must feel like. You know, we try to explain to the teachers, for example, that it's kind of like for us working on high altitude. You know, because the teachers are really trying to hold on to something of what is this like? Because she looks fine. You know, that kind of way. So I think, I don't know, it's us trying to understand what it feels like for them, and then trying to explain that to others, but also letting them do so much exercise that they can have a built-in opt-out for the child. Do you know that sort of way?
I think the information to teachers has to be very specific for each child, because you get the extremes with PE teachers sometimes where they don't want them to do anything, or at the other end of the scale then they want them to do absolutely everything. So, and what's appropriate is usually somewhere in between, and things like being allowed to rest when they feel the need to, because most of them do know when they need to rest in that kind of setting.
What age did you find that came? Did that come out of the study that more when they were in teenage?
It is. It's more as they get into sort of from 11, 12 on. The younger children just go flat out, and then they suddenly realise, well, I'm done here. I'm going to have to stop for a while. So they will limit themselves, but the older ones are a bit more sensible about it. Yeah.
But when they get older, do you not find that they just opt out? Well, particularly a girl, I'm 17-year-old, she just couldn't be bothered, you know what I mean? Yeah. Because at that age, they're either Dorothy's into sport and Dorothy's not, but she's not bothered.
Yeah, I think that's right. That the teenagers become a bit more sensitive to the fact that they're not as good as others at sport, and.
She actually would be very fast.
Would she?
Yeah, if she wants to be, you know what I mean? But
she just chosen not to do it. It's important for her and others who, not everybody has to play sport, not everybody enjoys sport.
But she gets out. It's always worth me say to the PE teacher, if she wants time out, she's genuine, and they're fine. So, but now she knows she can just say, I'll time out.
As long as they have some form of exercise. Yeah. Sorry, yeah.
What do you think of trampolines with young kids post-Fontaine?
It's a very specific question. I was asked this question the other day. It was actually in the context of a child who had a rhythm problem of the heart more than a Fontaine. But I think that, I suppose with a young child who's post-Fontaine, I wouldn't ban them from a trampoline, but I think the danger is that when they get onto it, they can do too much. And so I think that's one kind of activity where it's very constant. We were talking there just about having to have breaks in what they do. So if a child goes onto a trampoline and jumps on it for a prolonged period of time with a Fontaine or any other complex thing, I think that's not the best thing to do. Yeah.
Do you have a young child post-Fontaine as well who's starting to look at other kids like playing soccer or with all these kind of other activities?
Yeah.
Starting to say, well, I want to do this and I want to do that.
Yeah. Can I ask you what age the child is? What age is your child?
Well, my child's only 4.5. He's watching his brothers now, and I want to do karate, mom, and I want to do. Yeah. And he's doing all the actions, and up here, he want to do it.
Yeah. And at 4.5 and through the early part of childhood, he won't be too much different from the others. The problem arises then when they get into it, and then they find when they're coming into teenage years, when the coaches are wanting them to do more and they're not able to do it. I think it is important at a young age that if they want to play around with football and do that at that stage, that they are allowed to do it. But I think as parents and as doctors, we have to maybe try and steer them a little bit as they get older towards things that are more appropriate for them. And that's the trick, because sometimes when we now see teenagers who are diagnosed for the first time with, say, a rhythm problem of the heart, and you try to change their lifestyle, it's very different. So if you can steer them from their sort of 7, 8 on into things that they're still going to be able to do whenever they're older, that's better. But at your boy's age, maybe it's a girl at 4 or 5, I don't think you need worry too much about what they'll do. I think they'll I think at the young age you can. Yeah.
Sorry, can I just ask, just mention about rhythm and disturbance there. Is that something like Wolff Parkinson White or what?
I'm sorry, I just didn't hear the first part of what you said.
Just about, you're saying about rhythm.
Yeah.
Are you talking about Wolff Parkinson White or something like that? Or?
No, it was actually a patient who had long QT syndrome that I was mentioning.
Do you have recommendations that, say, I could look up on the internet or read the report about people with rhythm?
With
you know, for exercise for them.
Yeah, there are a couple of websites that they know there's but most of those websites are a bit alarming in that they talk about sudden cardiac death, you know. So I suppose what I would advise is that given your own child is to take advice from the cardiologist that knows the detail of your own child's problem. With Wolff Parkinson White, the risks with exercise are very small. Mostly the symptoms occur at rest, as you probably know, rather than with exercise. But increasingly with Wolff Parkinson White, there is the opportunity to do an ablation, you know, to take away the problem as the child gets older. And I think increasingly that's the way it's managed.
The Actigraph looks amazing. It's so small and so, you know, concealed to measure such great information.
Yeah.
I find my daughter, she gets her gets a Holter fitted every 6 months, I'd say. She completely takes to the couch wearing the Holter. It's like it has a psychological effect. And I wanted to move on it because it's supposed to be reading, you know, any change. So right, honestly, she won't go to school with it now, and I asked her why, and it's bulky, the wires, the thing hanging off her, it pulls, it's itchy. Is there any advances at all on the Holter becoming a bit more?
There are some of the newer Holters that we have now. I'm sure they have them in Crumlin too, but they are much smaller now and clip just into the top of the belt. You know, which, because you're right, that's what the problem with when we ask for Holters is that you get the diary back and they haven't done very little while it's on, and it's a waste of time. Oh, absolutely, yeah. When a patient or young person has a Holter on, you want them to do the things that they normally do, you know, and to go to school or if they're doing some exercise during the day, normally to do that. But it's very hard, I know it is. Yeah, no, the Actigraph won't give you ECG. It just gives you the activity levels, but it gives very useful information for what we use it for. But the Holters, I'm sure with technology, you know, Holters will probably become a thing of the past. You'll probably get some kind of little patch that you'll put on that'll record all of that, or you know, in a few years' time, that's what will come. But oh, you can, yeah.
Do you know, with a normal person, if they were exercising, if I start exercising now, I'll probably last for about 10 minutes, and then and then after a week you can extend it a little bit more. With a child who's got a heart defect, once you find that child's exercising and they actually get tired, do you actually, the next time you kind of push them, once they get tired, let them rest and then push them a little bit more, or do you actually go back the other way?
No, it's a very good question. For most of them, you can try and push them a little bit more, because part of what we're finding with young people with heart problems as well, it's similarly to adults. If you're out of the habit of exercise, then your heart and your muscles need a bit of training to build it up. So again, I'm always a wee bit wary about giving general advice for every patient. What I feel is that you, in terms of looking after young people, that it's specific advice for what's going on with that patient at the time. But as a general rule, trying to encourage them to do a bit more is a good thing to do. Yeah.
What about SATs levels during exercise?
Yeah. For children who have repaired heart problems, their saturations should be the same as a normal person. So the only people who should desaturate with exercise or commonly desaturate with exercise are people who have a Fontan type circulation, a single ventricle heart, and they will desaturate with exercise.
And is there a cut-off below which they shouldn't go?
Well, children with with a Fontan circulation will normally tolerate well saturations, you know, down as to around about 80%, and below that then they start to feel it a lot more. So I suppose that's a rough guide. It's hard to put an exact figure, but that's, and you would find that they would come down to that level, even 75% sometimes towards the end of exercise.
Sorry, so in that circumstance, I mean, would a kid generally self-regulate? I mean, would they know
They would.
themselves?
Yeah, they would.
So
Yeah, they would
so it's
self-regulate.
really just it's a matter of paying attention to where your kid's at rather than the actual.
Yeah, because in real life, a lot of the you won't have a number, you know, so you just have to judge on how they look and how they feel. Yeah.
They will know that, because they get to know that themselves.
They do.
You must find that climate has a huge difference in it, isn't it? And I find that the winter for
Yeah.
our daughter is longer, like worse than like if we're away in the sun or something, you know.
Yeah,
Or her school conditions. They've just got a new school, and her sick days in the previous building, because it's prefabs and the temperature is all over the place. Some days it was freezing and some days it was really hot. Really made a difference on health and well-being compared to the new school building now. Consistent heating, you know. So it's
no, this time of the year, from here on in, is the worst time of the year for young people with Fontan and single circulations, because their peripheral circulation isn't as good, and they're so sensitive to and feel the cold. And so, as you say, when you go on holiday, then you find that they're better than they are here.
Have you ever studied anything with swimming as well? You know, like with breath and swimming, you know, the breathing on, you know, to your breaths. Is that a challenge for Fontan children as well, to get that regulated breath thing with swimming, you know?
I have to be honest and say that I don't know. I haven't looked at that in detail.
No, it's just a good exercise.
Yeah.
If you get a warm pool, it's a nice thing for
Yeah.
our children, but it's I always wondered about that with the breathing, of trying to regulate it as in compared to children that don't have a heart problem.
I imagine that they should be able to cope reasonably well, and if they, but I don't know. It's not something I've studied in detail. Okay, thank you. Thank you. Not at all.
Really
Okay,
interesting.
all right, thank you. That's great.
We have some tea and coffee at the back, and those gorgeous biscuits that they have this morning.